Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes, and this is part of our classic clinical presentations. Today, we're going to meet Avaso. Meet Avaso. She is a 23-year-old woman with sickle cell disease. She has suffered greatly from complications of this disorder, but she keeps on going. She is the only one in her family that has sickle cell disease. Her parents both have sickle cell trait, and they had no symptoms. One of her brothers has sickle cell trait, but her sister is fine. Her parents found out she had sickle cell disease when she was 6 months old, and her hands and feet swelled up, and they were very painful. It started with 2 or 3 fingers, but then involved her hands and her feet. Sickle cells block the small vessels and bones in the digits. The sickling caused bone infarctions, which was very painful. This is called dactylitis. It is sometimes referred to as sausage fingers. The symptoms had been present for 2 days, and when she presented to the hospital, she had a low-grade fever. It was treated just like any other vasoocclusive crisis after the doctor found out that both patients had sickle cell trait. The reason it manifests as a toddler is because the fetal hemoglobin is protective. In newborns, approximately 60 to 80% of total hemoglobin is fetal hemoglobin. After that, the hemoglobin S starts to express itself. The red cells appear normal under normal circumstances, but in situations of stress, the cells will change form and turn into something that looks a bit like a sickle. Red blood cells are typically shaped as biconcave discs to maximize surface area for oxygen loading. It also helps to keep them distensible so they can slip through the capillary beds and the spleen sinusoids for about 120 days. When you have sickle cell disease, the cells will sickle in response to stress, like hypoxia, acidosis, fever, and cold temperatures. At that point, they are not distensible at all. If enough of them sickle, it can cause clumping and obstruction, which leads to a vasoocclusive crisis. Cells sickle because of a mutation in a single DNA pair, where glutamic acid is replaced by valine. Sickle cells sickle because this genetic mutation causes an abnormal type of hemoglobin called hemoglobin S. It causes the hemoglobin to form rigid, rod-like polymers under low oxygen conditions. This polymerization process distorts the normally flexible disc-shaped red blood cells into stiff crescent shapes. These sickled cells in this photo are causing an obstruction that led to distal ischemia. This can be exceptionally painful. It most commonly occurs in the muscles and bones of the thighs and back, but can occur in other places, like the lung, which can result in lung infarctions. These areas will not be able to allow oxygen into the blood. Since hypoxia promotes sickling, this can lead to severe hypoxia, which causes more infarcts, which causes more hypoxia, and the cycle continues. These infarcts also cause inflammation that can ultimately lead to pneumonia, which would cause more sickling. This complication is called the acute chest syndrome, and it requires IV fluid, oxygen, pain medication, and an exchange transfusion where they take out the patient's blood with the sickle cells in it and replace it with normal cells with normal hemoglobin. In 2010, she was hospitalized with osteomyelitis, a bone infection in her femur that was caused by salmonella, a very unusual bacteria, but it can cause osteomyelitis in sickle cell patients, and it happens more often in children. In 2021, she had cholecystitis. that caused her to have a severe vaso-occlusive crisis. It is not uncommon for people with sickle cell to have cholecystitis. The breakdown of red blood cells caused by hemolysis leads to excess bilirubin circulating in the blood, which ultimately can form gallstones that can lead to inflammation in the gallbladder. The spleen is the graveyard for all red blood cells, but it typically happens after they get old, at about 120 days. Red cells usually slip through the sinusoids in the spleen. They have to slip through tiny little holes. If they are old, meaning about 120 days old, they are a little stiff and they're not really able to squeeze through those sinusoids the way they should. They get trapped in the space between, and macrophages break them down into their component parts. The macrophages in the spleen start the process of hemoglobin recycling. Hemoglobin is broken down into globin, which breaks down into the amino acids that are returned to the protein synthesis. Heme is broken down into iron and porphyrin. The porphyrin gets metabolized into bilirubin, which circulates in the blood. Sickle cells, like old red cells, are unable to slip through the sinusoids in the spleen, and they get trapped in the space between and they are destroyed by macrophages. In childhood, when the sickle cells are being destroyed, it causes inflammation and enlargement of the spleen. Ultimately, the sickle cells cause infarction of the spleen. The person becomes functionally asplenic. One of the jobs of the spleen is to remove encapsulated organisms or bacteria. Without a spleen, the sickle cell patient becomes weak to these encapsulated bacteria like Streptococcus, Staph aureus, Salmonella, Meningococcus, and Haemophilus influenza, and more. Luckily, now there are vaccinations for most of these that are given to sickle cell patients in order to protect them. The conjunctiva of the eyes in patients with sickle cell in crisis frequently appear to be yellow or jaundiced. This is from the circulating bilirubin that is the byproduct of red cell breakdown in the vessels in the spleen. The more jaundiced they appear, the more hemolysis is happening. Now let's return to Avaso in current time. It is winter, and we just had a huge snowfall. Avaso is outside, dressed warmly to remove the snow. But it seems like she was out there too long because she started to get pain in her thighs and back, consistent with previous sickle cell crises. It got pretty bad quickly, and her pain medication at home did not help, so she went to the hospital. The doctor asked her about her symptoms. She said she had pretty severe pain in her back and thighs. This is her typical symptoms for her sickle cell crisis. But today they came on quickly and they are particularly severe. She usually needs to come to the hospital every 3 months or so, and she rarely needs to be admitted. It is important when you have a patient who has chronic recurrent diseases that you ask the pattern that is normal. Because, especially in the case of a sickle cell patient, a typical crisis can be something that is treated easily. An atypical crisis can lead to death. So it's really important to gather this information so you can determine if it's a typical or atypical crisis. A typical crisis is common pattern in the pain crisis, so it's in the same place as it usually is. It may be more or less severe, but the pattern is the same. Usually, the cause is also the same. Treatment can be decided by the response during previous crises. Same stuff, different day. It's patterned. It's an N of 1 study. You compare the person to the person, then come up with a plan. Atypical presentations typically can be when the patient comes in with a fever, as infections can be very devastating to sickle cell patients. If the pain is different than previous or typical pain crises, such as if they have chest pain or dyspnea, this can be an entirely different pain crisis that can be very serious. Things that can be the most serious include chest syndrome, infections, and aplastic anemia. These require a big workup, and the patient will need to be admitted. The treatment can also be quite different when you have an atypical crisis. Miss Avaso, I am a research assistant, and I was wondering if we could talk a little bit about your pain. We are doing a study, and your experiences could really help us. I am trying to get a sense of the severity of pain in a vasoocclusive crisis. Do you have anything to compare it to? Well, I have two children that I delivered without pain medicine, and I had a kidney stone once. How does your sickle cell pain crisis compare to those? The sickle cell pain crisis, and I mean pretty much all of them, are significantly worse than childbirth or the passage of a kidney stone. Thank you, Miss Avaso. Patients with pain crisis can be treated with incremental dosing of pain meds. But if the pain is severe, those low doses of pain medications are like a tease. They keep asking for more and more, trying to get rid of the pain. When they come in severe pain, they are looking for relief. In this case, a higher dose or two initially can really decrease the amount they need for pain control. The incremental small doses just tease them with the possibility of pain relief. Ultimately, they need so much more over a longer course of time. The front loaded approach is significantly better in patients with typical pain crisis. Now, no one is trying to tell you that you need to overdose the patients with narcotic pain medicine. Absolutely not. But more in the beginning usually really helps these patients immediately. They get out of the hospital faster and they feel much better. No teasing involved. I think this approach might be good for you. Would you agree? I would be glad to try it. Okay, I'll discuss it with your doctor. Her labs have returned. She is anemic and her reticulocyte count is elevated. Why do we do a reticulocyte count in patients with sickle cell? Reticulocytes are slightly immature red cells that have no nuclei, but they are a little bit more spherical than the mature red cells. Reticulocytes are typically found in the bone marrow only. But if a person is anemic, the reticulocytes may be sent out into the peripheral blood to replace what has been lost. It is a normal response of the bone marrow to red cell loss. Aplastic crisis is a tragic complication of sickle cell disease. Sickle cell patients are susceptible to parvovirus 19. Parvovirus 19 infects erythroblasts in the bone marrow, causing an acute and devastating decrease in red blood cell production. We check reticulocytes to make sure the bone marrow is responding appropriately during a pain crisis. If there are no circulating reticulocytes, the patient is at risk for an aplastic crisis. The treatment is to continuously transfuse the patient with red cells until the bone marrow recovers. We are giving you IV fluid and pain medication, as well as warm blankets to try to stop this vasoocclusive crisis. If it resolves, we will send you home. If it gets worse, won't get better, or is atypical in any way, we would need to do more tests and admit you to the hospital. Remember, atypical presentations are typically admitted. Now let's check to see how Avaso is doing the next day. I feel much better. Thank you, doctor. All right, thank you so much for learning with me today. If you like these videos, please like, subscribe, and review. See you next time.